Diagnosis, Old and New Tools and Challenges, sponsored by the Southeastern National Tuberculosis Center. I'm Karen Simpson, Co-Executive Director of the SNTC. Before we start today's event, I have a few housekeeping items to go over. Today's event is being recorded. The webinar is scheduled for 1 hour, including the question and answer period at the end of the presentation. To verify your participation in this event, questions for the speaker at any time during the presentation by typing your question in the Q&A pod. Questions will be addressed at the end of the presentation. Welcome to the third of 8 sessions on Advanced Concepts in Pediatric Tuberculosis, sponsored by the Southeastern National Tuberculosis Center. Today we present Diagnosis, Old and New Tools and Challenges. Today's presenter is Dr. Entesar Husain, joining us from Kuwait. She trained in pediatrics and infectious diseases at British Columbia's Children's Hospital, Vancouver, Canada. She is currently medicine at Kuwait University. She is also a consultant of pediatric infectious diseases at MBK Hospital for pediatric hematology and oncology in Kuwait. Finally, Dr. Husain is a consultant at the National Advisory Board of Vaccination in Kuwait. Now I'll turn it over to Dr. Husain.
Can you hear me?
Yes, we can.
Okay, it's great to be with you guys today. I'm Entesar Husain, and I will be talking about advanced concepts in pediatric tuberculosis, diagnosis, old and new tools and challenges. And this is the third in these series of the basic concepts in pediatric tuberculosis. At the end of this presentation, the attendee should be able to describe old and new tools used in the diagnosis of tuberculosis in children. Also, they should be able to understand advantages and limitations of each tool in detection and diagnosis of tuberculosis, know the different samples that can be used and sent for diagnosis of TB, be able to identify the indications for examination of the cerebrospinal fluid in a patient with symptomatic tuberculosis, and finally, be able to evaluate a patient with suspected TB infection. In general, majority, 3/4 of infections, of TB infections in children manifest as pulmonary manifestation, while 25 to 30% have extrapulmonary manifestations. Among the most common presentations of the extrapulmonary TB in children are based on lymphatic presentation, followed by meningeal presentations. What are the challenges that face us as doctors to diagnose tuberculosis in children? Not all TB is not considered in the diagnosis, in the differential diagnosis of children, especially in areas with low endemicity. Tuberculosis can mimic many common childhood diseases and infections, including pneumonia, viral infections, malnutrition, and HIV. The physical manifestations of tuberculosis vary and differ with the age of onset. While younger children can manifest with any manifestation and look sick and very ill, older children tend to have pulmonary TB and look totally asymptomatic. Finally, one of the major challenges that TB in children has possibacillary nature. 1 milliliter of sputum in children has been reported to have 10 to the power of 4 of colony-forming unit of acid-fast bacilli, which is on the threshold of detection, which make detecting tuberculosis in children very difficult. Before I go into the presentation, I would like to present 3 cases that I would like the audience to be to keep in their mind before we answer them towards the end of the presentation. And hopefully, my presentation throughout will help them to figure out how to diagnose these cases. The first case is a 5-year-old girl from Egypt who has been long-standing having failure to thrive and anorexia. She has persistent cough associated with wheeze, and she partially has responded to bronchodilators. She had recurrent febrile illnesses, for which she has received various courses of antibiotics. She has been treated in the past 6 months as a bronchial asthma, where prophylaxis have been prescribed for her, but still she had no improvement. This is her chest X-ray, as you can see here. This is her chest X-ray. The question here, think about how would you manage this girl. So this is the first case. The second case is a 2-year-old boy from the Philippines who had presented with the right cervical lymphadenopathy measuring 2 by 3 centimeter for the last 1 month. He had received 2 courses of antibiotics. The first one is oral clindamycin for 1 week, and then when he did not improve, he was admitted to the hospital and received intravenous cefuroxime without much improvement. He is thriving well. As you can see, his weight and height are within appropriate centiles. And 1 week before presentation, he developed stridor. This boy was vaccinated with BCG when he was in the Philippines at birth. Again, the question is, what should be done next for this child? The last case is of a 1-year-old girl who presented or who had been vomiting in the last 24 hours and presenting with deteriorating level of consciousness. In the past 1 month, she has unexplained febrile illnesses. For the last 3 months, she's been taking care from a nanny from Ethiopia in the last 3 months. So what will be the best diagnostic test to perform on this girl? I think now we can move on to talk about diagnosis of TB. Of course, in terms of diagnostic priority, the diagnosis of active TB remains of a high priority. On the other end, diagnosis of latent TB infection is also a priority because all these cases, if they were not detected, adequately treated, will end up with active TB. So we have 2 ends of 2 extremes on the scale: latent TB infection and active TB infection. Latent TB infection has been covered thoroughly with Dr. Maraka in the last session and basically talked about TST, skin testing, and IGRAS. What I will be today talking about is how to diagnose active TB. I will be presenting 4 different approaches to diagnose active TB. The first approach is symptom-based, the second is radiological-based, the third is immunological-based, and finally, organism-based approach. First, symptom-based approach. Now, this can be used fairly in endemic countries where there are limited resources to diagnose TB, and also can be used in low-risk children who are immunocompetent, who are in the older age group above 3 years of age, because these are the category where TB will present or show in a slowly progressive fashion. The main disadvantage of this clinical scoring system is it is severely limited by the absence of standard symptom definition, and it's inadequately validated. The clinical scoring system consists of well-defined symptoms which are persistent and has non-remitting nature or character. Most helpful symptoms include persistent, non-remitting cough or wheeze, history or documentation of failure to thrive despite food supplementation and adequate nutrition, if the child presents with fatigue or reduced playfulness. This can be adequate. This can be an entry to diagnose or think about tuberculosis. In terms of diagnosing of TB cervical lymphadenitis, patients who are presenting with persistent more than a month of lymph node enlargement can be thought of having TB. The size matters if it is more than 2 by 2 centimeter, and if there is no visible local or surrounding cause, and if the lymphadenitis or lymphadenopathy did not respond to first-line antibiotics. What about radiologically based approaches? Chest X-ray remains the most practical and helpful test in everyday practice. It usually provides accurate diagnosis with suspicious symptoms if it is evaluated by an experienced clinician. The only limitation of chest X-rays is that it is subjective. It has subjective interpretation. It's a great test. Sensitivity can reach up to 70 or 80%. Specificity is less, 60 to 70%. Despite these adequate sensitivities and specificities, there is a huge interreader variability, and the interpretation is highly variable and depending on the radiologist's experience. Now, I'm going to go through a series of X-rays to show you how children with tuberculosis, pulmonary tuberculosis, present with their variation of chest X-ray. This is a child who had a TB, but he has a normal chest X-ray. You can see here a little bit of an infiltrate, but usually because of the small lymph nodes and adequate airways, the chest X-ray as a presentation can be normal. Compared to this chest X-ray, where the child has primary tuberculosis, a large lymphadenopathy, and a mild infiltration here. This is also a presentation of a child who has TB, where the hilar lymph nodes has enlarged and resulted in enlarged mediastinum, as you can see here. So this is hilar and mediastinal lymphadenopathy, which is highly suggestive of tuberculosis. Lymph node enlargement can result in caseation and obstruction of one of the major airways, which result in secondary atelectasis, and this is working similar to a foreign body obstruction. Another presentation, again, where the lymph node can obstruct an airway and result in compensatory emphysema, as the way it is happening here, where there is a mediastinal shift to the right. Another presentation is miliary TB. I think everybody is familiar. This happens in malnourished children and children with TB, where there is disseminated tuberculosis. And finally, cavitating lung disease. This is a patient who has tuberculosis, and here is presenting with a cavity. And this is also a manifestation of pulmonary TB. Chest CT scan, high resolution CTs are mostly sensitive tools which are available to detect hilar lymphadenopathy or early cavitation, and also they can differentiate between caseation and the normal or homogeneous lymph nodes. We move on to talk about immune-based approaches. The problem with these immune-based approaches is that tuberculosis has wide clinical spectrum of diseases. It varies from LTBI to different form of active disease, which can be mild or severe. There are other factors that influence the immune response to these tests, such as BCG vaccination. In addition, there are exposure to environmental mycobacteria, which can make these immune tests positive in a situation where it is not Mycobacteria TB. And lastly, HIV co-infection, which affects the immune system and make these tests likely to be misleading. TST test has been talked about thoroughly in the last presentation. It is a skin test, beautiful, but it lacks both sensitivity and specificity because it can detect other than Mycobacteria TB. T-cell assays like T-spot test and quantiferon like quantiferon TB Gold are more specific than T-test, but they do have their own limitation. They fail to differentiate the LTBI from active diseases. They require a large amount of blood from a child to be for examination. In addition, there is a limitation of data in children. The test, there are a lot of reservation about using T-cell assays in very young children. And lastly, but not the least, it is expensive. So it cannot be processed or handled in countries or places with limited resources. Now, there are new diagnostic approaches, immune-based, including antibody detection, antibody assays, and the use of a transdermal test, which specifically called MPB64 skin test. And both of them are aimed to diagnose active TB, a probable active TB rather than LTBI. The only problem with the two tests that they have been not validated or with limited studies in the pediatric age group. Finally, let's talk about the organism-based approaches. Microscopic examination remains the cornerstone of diagnosing TB and controlling TB. As you might be aware, the standard is to use the Ziehl-Neelsen stain, which require light microscopy or bright field microscopy. In addition, there is another stain, which is Urine stain, which requires fluorescent microscopy. In most of the developed countries or high-income countries, they use fluorescence microscopy as the standard practice instead of Ziehl-Neelsen stain. And I will show you the difference. So this is a Ziehl-Neelsen stain where you can see here the acid-fast bacilli compared to the fluorescence or to the Urine stain, where you can see the acid-fast bacilli shining, fluorescing. Now, the advantages of microscopic examination, it's rapid, it is inexpensive, so it can be used in all the countries, even with limited resources, and it identifies majority of infectious TB patients if acid-fast bacilli were present in the sample. The disadvantage is the sensitivity. It has a huge variable sensitivity. It can range between 20% and 80%. The sensitivity is basically determined by so many factors. It is dependent on the type of specimen. The specificity of microscopic examination is higher in respiratory samples. It is less in other, for example, peritoneal fluid. It is also dependent on what type of population. And in areas where there is low TB incidence, it can be falsely positive for non-tuberculous mycobacteria. Also, sensitivity is dependent on stain used. For example, with Ziehl-Neelsen stain, it can detect 100,000 bacteria per ml, while the detection rate is less or with less amount of bacteria for a fluorescent, up to 10,000 bacteria per ml. So it varies with the method used. Also, it depends on the experience of the microscopist, if they have been experienced with seeing acid-fast bacilli or not. And finally, sensitivity is less in children. It depends on the age of the patient. Older children tend to have more sensitivity, or the sensitivity increases in older children as compared to younger age group. And finally, the smear microscopy, it can tell you there is acid-fast bacilli, but it cannot determine the drug resistance, and this is one of the pitfalls. Culture, positive culture remains the standard, the gold standard for diagnosis of TB in a child who is symptomatic. It can be done in solid or liquid broth media, and the advantage, it's not only providing, is it positive or negative culture, but if it is positive, it can also provide susceptibility of the mycobacteria. The limitation, it has a slow turnaround time. Usually it takes between 6 to 8 weeks to culture or to finalize the result of the culture of mycobacteria TB. It is expensive. It depends if it is automated liquid broth systems. It has poor sensitivity in children who have active TB. Cultures tend to be negative in 70% of children who have probable TB. And finally, it's expensive in poor resource countries. There are new diagnostic approach, again, to detect microorganisms. Examples like caloric cultures, specific cultures like TK medium, and phage-based tests, and microscopic observation of drug susceptibility or MODS assay, and all of them are, the objective of all of them is to diagnose active cases of TB. The disadvantage, none of these 3 tests have been well validated or established in children. PCR assays have been used to diagnose active cases of TB and resistance to rifampin. They are rarely available in endemic area, and their sensitivities are poor because of the paucibacillary TB nature in children. However, they can be of a better outcome if they were used in non-pulmonary samples, for example, like CSF. Though they have been extensively evaluated, but there is no evidence that to favor the widespread use of PCR to diagnose TB. Now, we move on to talk about what samples should be used to evaluate patients with tuberculosis. I guess everybody by now knows that gastric aspirate is the main standard in pediatric population. It is indicated in children with possible TB who cannot expectorate sputum. So probably it's for children less than 7 years of age. Usually it consists of collecting 2 or 3 fasting, early morning samples as gastric aspirate. So a gastric tube or a nasogastric tube has to be inserted to collect the sample. The advantages, it is microscopically, it can detect between 0 to 21%. Culture can detect, again, variable number between 0 to 75% in children who have clinical diagnosis of TB. Disadvantages, it's an uncomfortable procedure, as you can imagine, inserting a gastric or a nasogastric tube. It's unpleasant for a patient, and it's difficult to implement. It has to be performed immediately upon the patient, when the patient wakes up. So it cannot be done as an outpatient. The patient has to be hospitalized to do that test. Induced sputum, the induction of sputum is through the use of 3% hypertonic saline. A single sample can have the same yield as a 3 gastric aspirate. Sensitivity is high. It can detect 75 to 100% of culture positive TB cases. And in addition, the yield is not only higher for gastric aspirate, but it's also higher for nasopharyngeal aspirates. The limitation, again, the patient needs to be hospitalized for induction of sputum, and also induction of sputum pose a nosocomial risk transmission if no adequate infection control precautions have been taken into place. Third is the sputum. At least sputum samples of 5 to 10 ml are needed to be collected to be tested for microscopy as well as culture. The disadvantage, only 10 to 15% of the sputum sample can reveal acid-fast bacilli. The yield of the third sample or the third sputum smear is only 10 to 5%, and the yield of the third culture is 5 to 10%, especially in HIV-infected people. Bronchoalveolar lavage is another sample, a respiratory sample that can be used when spontaneous sputum or induced sputum are unavailable, or they have been negative and you're still suspecting that the patient might have TB. Now, the disadvantage, it poses a discomfort to the patient, it is expensive, and also it contributes to nosocomial spread of TB if it is performed without appropriate infection control measures. The yield, though, is very high, up to 77%. What about pleural fluid? If the patient had pleural effusion, usually the color can be yellow, it can be tinged with blood. The characteristic of the fluid obtained can have a characteristic of mild exudate with a little bit of elevated protein, low sugar, a little bit high white blood cells. Acid-fast bacilli smears tend usually to be negative because there are very few organisms there. The cultures, however, can be positive in 30 to 70% of the cases. The thing which has really good yield is a biopsy of a pleura because it is likely to yield acid-fast bacilli stain, positive culture, and there is an evidence of granuloma formation. Urine is non-invasive. There is excretion of Mycobacteria tuberculosis in the urine, which has been well documented. And there are new sensitive bacteriological or antigen tests which are being tested to detect tuberculosis. Bone marrow, again, they are very good samples. They are resources that can be considered in cases with probable, which has disseminated TB. Cerebrospinal fluid, again, it's a fairly invasive procedure. The bacteriological yield is low, but the CSF analysis, which I'm going to show later, is important to know, and it can guide you towards the diagnosis of TB. It should be considered if there are signs suggestive of tuberculous meningitis. And usually these signs are subtle in young children, and you really need to have high index of suspicion, especially in endemic countries. The characteristics of the cerebrospinal fluid include white blood cell count between 10 to 500. Initially, there can be an increased neutrophil, but later there will be increase of lymphocytes. The glucose is characteristically very low. It's less than 40 milligram per deciliter, but it can be even as low as 20 or lower. Protein can be as high as 5,000 milligram per deciliter. In 5 to 10 ml of CSF, usually acid-fast bacilli smear is positive in 30% of the cases, but the culture can be positive in up to 70% of the cases. Fine needle aspiration, it has an excellent bacteriological yield. It has minimal side effect, though it is invasive, and this is the procedure of choice in children who have superficial lymphadenopathy. So before we go to the cases, I would like to conclude that acid-fast bacilli microscopy and culture in pediatric population remain the gold standard for diagnosis of TB. Till now, we don't have a test with greater discrimination to diagnose TB. In general, if there is a child with a positive skin test and clinical or radiological findings that suggest tuberculosis and a history of contact with adult who has TB, the child should be treated for tuberculosis. The drug susceptibilities that should be included or used in the child is similar to the adult contact to that child. PCR might be an aid in the diagnosis of extrapulmonary TB. Still, we're waiting for biomarkers, novel biomarkers, either in the blood or in the urine, so we can reliably distinguish active from LTBI in children. Now we go over the cases that I have presented earlier, and hope by now you have formulated a management plan to diagnose these cases. Let's move on to the first case, where, again, to remind you, a 5-year-old girl who's Egyptian with failure to thrive anorexia, who had persistent cough associated with wheeze, partial response to bronchodilators, recurrent febrile illnesses, treated with bronchial asthma for 6 months without any improvement. And if you look at the chest X-ray, let me show you here, there is a little bit of infiltration despite several courses, despite she has been treated as a bronchial asthma for a long time. So this lesion was very suspicious. She was taken care of by the pulmonologist, who decided to look at this lesion further and did this CT scan of the chest. So this is what he found. He found here dilated airways, multiple dilated airways, not only where the lesion is, but it's more bilateral, more on the left. So it is bilateral, and that's what raised the suspicion if this child had pulmonary TB. There is no history of contact with TB for this particular child. So TST was done, which showed 7 millimeter in duration. She was admitted for early morning gastric aspirate for 3 days. That was taken. Unfortunately, the acid-fast bacilli were negative, but subsequently the TB cultures were positive. And let's look at the result of her aspirate, and you can see here. Oops. Okay, so the culture have shown mycobacteria, tuberculosis, which is pan-sensitive to all anti-TB medication. But look at this. The sample was sent on the 24th of December, 2005, and the result came back on the 5th of February, 2006. 2 months to diagnose that patient who's been around for 1 year or 6 months. The second case, who is the 2-year-old boy from the Philippines who has lymphadenopathy not responding to neither oral or IV antibiotics, and it is of a big size, 2 by 3 centimeters, though he's been thriving, but he developed stridor, which made the doctor who was seeing him to do this test, chest X-ray. And you can see he has a mass, a big mass over here. Now, that was very suspicious that whether this could be lymphoma or not. So subsequently, TST was done, which showed here the result. And you can see here there is a huge induration, measured probably 22 millimeters in duration, and there is a central ulceration. So that was, in addition to the presentation of that lymph node, highly suspicious whether this lesion is TB or not. The final confirmation came when the chest CT scan was done, and I apologize for the poor quality, but this is what I had on my file. As you can see here, this was a huge lymphadenopathy, but I hope you can appreciate the difference between the 2 areas here, the white area and the darker area, which was described by the radiologist as a central necrosis of that lymph node. And subsequently, there was a fine needle aspiration done for the cervical lymph node, which was 3 by 2 centimeter. The direct microscopy showed acid-fast bacilli. Pathology showed granuloma, and they were able to stain for acid-fast bacilli. And the culture showed Mycobacteria TB, sensitive to all first-line anti-TB medication. We move to the third case, an unfortunate 1-year-old girl who had vomiting, deteriorating level of consciousness for 1 day, fever, febrile illnesses. She's been taken care of by an Ethiopian nanny for the last 3 months. Because of the presentation mainly was CNS here, deteriorating level of consciousness, this girl's immediate action was that she had a CT scan of the head. And this is the result. And as you can see, she has dilated ventricles. And she had loss of rogi in her brain. So almost here she had a brain edema. And subsequently, the neurosurgeon was consulted for this girl, and they decided that the best thing is to put a shunt. So she was admitted to the ICU. The neurosurgeon was consulted, and a shunt was inserted where we were able to get CSF. Now, these are the findings on the CSF. WBC were 548. Majority of them were lymphocytes. She had high protein in the CSF, very low glucose. The gram stain was negative. Acid-fast bacilli stain were positive. The clinical progress of this girl, because of the acid-fast bacilli stain and the CSF was positive, she was immediately started with anti-TB medication. The CSF for TB PCR came back in 2 days. It was positive. She remained in coma for 1 week, and unfortunately, she passed away. The nanny was investigated, and actually it was found that she was coughing for 2 months. She has been seen by several doctors, and none of them diagnosed that this girl has this nanny was probably an active case of TB. Her chest X-ray showed right middle lobe pneumonia, and her sputum tested positive for acid-fast bacilli. Finally, the TB culture of the CSF of the girl came back after 1 month. It was positive. And this case highlights that it is important with nannies or caretaker who have been coughing for months to suspect TB, especially in countries which are low endemic, just to avoid the passing or the transmission of infection from the nanny to younger children. I think this is my last slide, and I thank you very much for listening.
Thank you very much, Dr. Husain, for that presentation. I do have some questions that some of the audience have asked. So let me start with more like a comment than a question, but I would like to hear your input on this. One of the attendants commented that they actually use induced sputum. They are able to use induced sputums in children, even in the clinic as outpatient, and they have been able to use that even in kids as young as 3 years of age. So any comments on that?
Yes, you can do it in children who are, if that clinic is well equipped, it has good infection control precautions or measures, and if the patient can come, and if they have the standard, I think it can be done. Not necessarily patients need to be hospitalized. I think in my country, this is what we are doing. We hospitalize patients. And in young children, it can be induced, and the sputum can be induced with hypertonic saline, even younger age group, 2 years old, if they can induce the sputum and these children can cough. I think it can be done. If they have the setting.
Exactly. I think that is really the key thing. Not every clinic has a setting to. Here in Jacksonville have had the luck with inducing sputum in the kids in the clinic, and that really helps to avoid the expenses of the admission to the hospital just to obtain the samples. And so that has been helpful. And the other thing that I have to comment on that is that there is actually published literature, mostly from South Africa, where they actually use induced sputums even in babies. But what they do, that is in the hospital, but what they do is they actually induce the sputums with hypertonic saline, but instead of having, obviously you can ask the baby to cough in a cup, they actually do aspiration,
Gastric
like
acid.
nasopharyngeal aspiration after they induce the cough, and their yield was actually quite good. They even compared to the yield of gastric aspirates, and the yield of the induced sputums doing it that way was higher, much higher than the gastric aspirate. So that is a technique that in some places they're starting to use, which is, as I said, even in babies as young as a few months old. But they do need to be admitted because they need to be watched for like bronchial
apneas and,
Exactly. Another question, can you comment on the use of stools to isolate Mycobacterium tuberculosis? Stool samples?
I didn't see anything while I was reviewing stool samples, and actually these days we have a child, and actually it's not a child, it's a 14-year-old girl who presented with melena, not actually melena, she was actually passing the fresh blood. So the gastroenterologists have done a colonoscopy, and they were able just to get a sample or a biopsy which showed it has a granuloma and acid fast bacilli positive. So she had intestinal TB. Now, it was diagnosed through a biopsy, but not through the stool. And actually, when I was reviewing the literature, I didn't find anything in the stool. And unless you've seen anything, Anna, I don't know. I cannot answer this back. I haven't seen anything on the stool.
There's actually some literature. Actually, there's literature, some in children, but I did find some literature on adults with HIV, and sometimes in settings where it's really hard, especially like in underdeveloped countries where it's really hard to obtain sometimes induced sputums. They actually there's a study in patients with HIV that they were able to isolate with a pretty good success rate Mycobacterium in the stool. Now, it doesn't necessarily mean that they had gastrointestinal TB, but what the thought is that the people, when they cough, they swallow their own sputum, and then they can actually excrete it in the stools. So there's some literature that looks promising. I think it's just something that needs to be validated a little bit more. But I think in children it would be probably a good thing if we can prove that it helps, because that way we don't have to do the gastric aspirates.
Yeah, of course, yeah.
So somebody asked in one of your in the case of the child with meningitis, if the child was vaccinated with BCG, and if the BCG then failed, wasn't protective?
Actually, this is the case. Probably it's an old case, probably presented in 2002 and 2003. And unfortunately, at that time, our vaccination schedule included the BCG at the age of 4 years. So we did not have BCG at birth or in early infancy the way we do it now. It was only in 2004 or 2005 that we switched from a 4-year-old to at a 3-month-old. We had a huge debate over the switching, but we finally were able to switch because of not only this case, other few cases who had TB, disseminated TB earlier in life, and that's why we did the switch. It sounds awkward the way it was, but this is the way I found it when it came back. So.
All right, no problem.
Yeah. So that girl, to answer the question, that girl did not have BCG, unfortunately.
Yeah. And just the answer to another person asked, is BCG protective?
BCG is not protective as per the meta-analysis. It's not protective against pulmonary TB. However, it is protective, or it decreases dramatically the incidence of disseminated TB, TB meningitis in infants less than, or in children less than 4 years of age. But still they can get pulmonary TB. So it decreases mortality, morbidity, affection in younger age group, dissemination and meningitis, but it's not an absolute protection.
Yeah, I think that's really important for the audience, especially in the United States, because since we don't use BCG here, we're not very familiar, or in general, the people are not familiar with it. And when we evaluate children that are coming from countries where they get BCG, it's very important to understand that they can still develop pulmonary TB, that the BCG is mostly for protection of more severe disease like meningitis and miliary, but it is not that effective for pulmonary, so that kids with proven even scars that they have gotten BCG can develop TB, and it's non-protective in that case. So that's a good question. It's good to clarify that.
And actually, sorry, can I just make a comment? And the interpretation of TST as per the Red Book is not entirely dependent on BCG. So disregarding BCG, you should interpret TST. Got it?
Yes.
Yeah. Okay.
Another question is, do you have any comments on the use of expert assay for the diagnosis of pulmonary TB in children? Are you familiar with that expert assay?
Gene expert. I think I came across when I was reviewing for this presentation. I'm not really, I didn't find anything solid to use gene expert in pediatrics. In adults, yes, it is used. I don't know.
Yeah, I think it's pretty much the same depending on the sample, I guess. But yeah. We've used it here in some kids and has been useful. So yeah, you can use it if obviously it's not available everywhere, but where it's available. How about the comment on the PCR, the use of PCR, more broadly use of PCR? I don't know if that was just the question.
More broadly, what do you mean? Like for sputum?
Yes, or for any sample in pediatrics.
Yeah, it's very good in fluid, in sterile fluid, CSF, peritoneal, pleural fluid. However, it's not of adequacy in the use of sputum, either induced or gastric aspirates. So we basically, because of the limitation, we don't always have PCR available. But whenever we have PCR available, we use it for extrapulmonary TB, like fluids. Extrapulmonary fluids, yes.
Yeah, I agree, and we also use it in tissue. Sometimes when we have either lymph nodes biopsy, you can actually use it on the tissue, and that can distinguish more readily MTB from non-tuberculous mycobacteria. So sometimes when it's important to try to confirm the diagnosis quicker, we've used it in tissue, and it has been good also. Another question. This is not something that you covered in your lecture today, but maybe you want to comment on this. They ask about the age limits to use the interferon gamma release assays versus the tuberculin skin testing in children. Like, what would be the age limits for one or the other?
The majority, they talk in young children. The assays are not reliable. So probably something like 5 or 6 year old is around the cutoff age. And this is what I discuss with my microbiologist here.
That is correct. I agree with you. I think we use 5 as the cutoff, and in all younger than 5, we definitely prefer to do TST and not the interferon gamma release assays. Above 5, it's fine. It's basically use one or the other, not necessarily both. I think we only use them together when there is for example, if the the TST is positive and the parents are from countries where the kids have gotten BCG and they are not convinced that is really latent tuberculosis infection, we sometimes use the IGRAS to just convince the parents that it is true infection, but it's not something that we do routinely, like sending both tests. We usually do one or the other. I think the use of both at the same time is only indicated for situations where it would basically benefit for adherence to the medications, and also when we have high-risk situations that the suspicion is pretty high. Sometimes we do both, just because then in those cases, either one of them positive, we take it as a positive.
Yeah.
Let me see if I have a, there is a question about treatment, but we're going to defer those questions for the talk. We have a special one for the management and treatment, so I'm going to just defer those questions for that other lecture.
Okay.
Let me see. I think that summarizes the questions. So thank you very much for your participation, and thank you, Dr. Husain, for your lecture. And for the audience, just a reminder that the next webinar is on November, the second Thursday in November. So it's less than a month away, just because this one was rescheduled because of ID week. So the next one is November 13th, and this one is about clinical manifestations. So I hope you join us there. Thank you.
Thank you very much, and I really enjoyed this experience.
Okay.